Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome my dear students in my surgery lecture number 101, that is the tumors of the breast. In this lecture we will explore the benign neoplasm, that is the Fibro-Adenoma, Phalis Tumor, Duct Papilloma, malignant neoplasm of the breast, that is the Carcinoma and Sarcoma, Paget's disease, TNM classification of the malignant neoplasm of the breast, management of the neoplasm of the breast and sarcoma of the breast and its treatment. All points will cover and explore in this lecture. Now first we start with the benign neoplasms. Fibro-Adenoma, Phalis Tumor and Duct Papilloma are called as a benign neoplasms of the breast. First we start with the Fibro-Adenoma. This is the most common benign tumor of the female breast. In the Fibro-Adenoma, it is a new growth composed of both fibrous and glandular tissues. Now the etiology behind this Fibro-Adenoma is this tumor is said to develop as a result of increased sensitivity of a focal area of breast to estrogen. It is also an acceptable fact that there is some relationship between excess estrogen levels and Fibro-Adenoma. That is why this condition may present simultaneously with fibroadenosis. Pathology: the lesions are encapsulated and tend to be spherical, but on occasion there may be the multinodular or somewhat irregular size and shape. Classification according to original: the hard Fibro-Adenoma, pericanalicular connective tissue separated by the elastic lamina, and soft Fibro-Adenoma, intracanalicular connective tissue outside this elastic lamina is there. And treatment of this Fibro-Adenoma is the excision biopsy, quadrantectomy or partial radical mastectomy. If the Fibro-Adenoma is big, the decision should be taken according to the size of the Fibro-Adenoma. Dear students, here is the cut section of the Fibro-Adenoma is clearly seen, which is a hard Fibro-Adenoma. Pericanalicular connective tissue separated by the elastic lamina is clearly seen in this image. Now the second neoplasm of the breast is the Phalis tumor. This Phalis tumor is a benign tumor, irregular surface projection. This phyllodes means this is a Greek word meaning a leaf-like. Occasionally, ulceration of the overlying skin occurs due to the pressure necrosis. Skin becomes warm, red, shiny with visible dilated subcutaneous veins, and degeneration and cyst formation is there. These Phalis tumors occurs predominantly in the premenopausal women around 40 years of age. On the palpation, the tumors has a fairly smooth margin, neither fixed to the skin nor fixed to the deeper structures. Axillary lymph nodes are not involved. There is no retraction of the nipple, and the treatment is a simple inoculation of this Phalis tumor. Wider excision is a requirement, and simple mastectomy is there. This is the simple treatment of the Phalis tumor. Dear students, here is the mammogram is showing the Phalis tumor. Huge Phalis tumors is clearly seen. Third entity of the tumors of the breast, benign neoplasm, is the duct papilloma. This is a benign tumor arises from the lining epithelium of the principal lactiferous ducts. The tumor is usually of small size. It is often said that the precancerous condition may turn into the intraductal papillary carcinoma. The treatment is very easy: complete excision and microdocectomy. Other benign neoplasms are neurofibroma, lipoma, papillary cystoidoma is also there, but it is not so weighted here to elaborate. Malignant neoplasms of the breast are: one is the carcinoma and second is the sarcoma. Dear students, here is a picture is clearly seen, that is the duct papilloma is clearly seen. Now the next point of this lecture is the breast carcinoma, malignant neoplasm of the breast. Malignant neoplasm of the breast is broadly classified into carcinoma and sarcoma, these two groups. Etiology of the breast carcinoma is age. Incidence of breast cancer increases with age. It is only occasionally seen in late teens. Thereafter, there is a rapid rise in the incidence of the rate up to the age of the 50 years. Second is the genetic factors. Family history of the breast cancer has often shown an increased incidence in the same family. Third is the childbearing and fertility. Single or multiple married women have a relatively risk rate of 1.5 compared to the pairless women. The effect of the parity on protective influence depends on the age of the patient at first childbirth. The fourth is the age of the menarche or menopause. The girls whose menarche occurs before the age of 12 years have a relative risk of the 2.5 compared to those starting menstruation after 12 years. Geographically, breast cancer is commonly seen in Western countries. It is still a rare tumor in Japan. Sixth is the endocrine. The role of the exogenous hormones, particularly oral contraceptives and hormone replacement therapy in the development of the breast cancer is still controversial. Next is the diet. Diet rich in saturated fatty acids may influence the risk of the developing breast cancers. Cancer of the National Academy of the Science concluded that the fried and high fat foods can increase the risk of the developing cancer approximately twofold. Similarly, high intake of the alcohol has been claimed to be associated with the increased risk of the breast cancer. Etiology factor is the benign duct disease. Some pathological entities such as the multiple papillomatosis, gross atypia or hypertropia are certainly associated with the increased risk of the breast cancer up to the 3%. Now the pathology of the breast carcinoma. Approximately 50% of breast cancers arise in the upper and outer quadrant, that is the 12 to 15% in upper, and inner quadrant is 6 to 10%, and in the outer quadrant is 3 to 5%. This pathology of the breast carcinoma derived from the duct system or the lobule. First, the ductal carcinoma of the breast is accounting for 85% to 90% of all cases. Ductal carcinoma in situ, it is characterized by the proliferation of the malignant breast epithelial cells confined to the duct system and does not invade the basement membrane or surrounding tissues. This solid or comatotype is most common and more virulent. Papillary or cribriform type is characterized by the papillary projections of tumor cells into the ductal lumen. Invasive ductal carcinoma, once the intraductal carcinoma has invaded the basement membrane of the duct, it has now the ability of infiltration into the surrounding breast tissues and is called invasive ductal carcinoma. In this, the infiltration ductal carcinoma with productive fibrosis, that is the serous carcinoma, accounts for 70% of invasive mammary cancers. Where the second is the medullary carcinoma, these cancers represent only 2 to 5% of all breast cancers. In this medullary carcinoma, dense lymphocytic infiltrates composed predominantly of lymphocytes and variable numbers of the plasma cells. Dear students, here is the image of a carcinoma of the breast. Next image is the carcinoma of the breast. Third is the sarcoma of the breast, is clearly seen in this image. Third type is the tubular carcinoma. This type of the breast cancer represents only 3% of all breast cancers. Well differentiated, macroscopically the cancer is small, about 1 centimeter in diameter and serous. Histologically, tubular differentiation is distinctive. Only 10% of patients develop axillary metastasis. And fourth is the mucinous colloid carcinoma. This carcinoma also develops from the ducts. These uncommon cancers constitute only 2% of the all breast cancers. Typically bulky mucinous and is largely confined to the elderly women. And the histologically, there is a large pools of mucins and surrounded variable group of the tumor cells. Fifth is the papillary carcinoma. This carcinoma accounts for less than 2% of the all breast carcinomas are generally seen in the old women around 70 years of age. Histologically, there is a papillae with the well-defined fibrovascular stalks and multi-layers of epithelium with the pleomorphic cells in this papillary carcinoma. And the sixth is the ascent cystic carcinoma. This lesion is very rare. Less than 0.1% of all types of the breast cancer carcinoma, this constitutes only. These cancers presents of small lesions 1 to 3 cm in diameter. Now the next type of the ductal carcinoma is the lobular carcinoma of the breast. This type can be conventionally subdivided into in situ and invasive forms of depending on whether the basement membranes of the lobules has been invaded. First is the lobular carcinoma in situ. Within the lobule, there must be uniform proliferation of the cells. The most important aspects of the cancer as it is potential for becoming invasive. And second is the invasive tubular carcinoma. This accounts for 10% of all breast cancers. The histological features include the characteristics like the small cells with rounded nuclei, inconspicuous nuclei and scanty in distinct cytoplasms are there. Now these are the classification and distributions of the neoplasms of the breast. Now next point is the Paget's disease. Sir James Paget in 1874 described this lesion, which is the chronic eczematous eruption of the nipple. Paget's disease constitutes approximately 1% of the histological types of the breast cancer. It is almost always associated with an underlying intraductal and invasive carcinoma. These constitutes 1% of all breast cancers, very rare. Weeping the eczematous lesion on the nipple which becomes red and thickened, the areola and surrounding skin may be involved, as well as the surface becomes the either scanty or crushed and moist and oozing. In the beginning, no mass may be felt, but eventually a swelling will develop beneath the nipple in the most of the cases. Histologically, presence of the Paget cell in the most diagnostic evidence. These cells are distinctly large. Symptoms including itching, burning, intermittent hemorrhage and tenderness. Inflammatory carcinoma. In this condition, the tumor cells are very undifferentiated and involve the subdermal lymphatics quite rarely. Now, the spread of the carcinoma: local spread, intraductal spread, and lymphatic spread. These are the spread of the carcinoma of the breast. Lymphatic spread from the emboli and permeation. Local spread: carcinoma of the breast spreads quite efficiently into the surrounding tissues by infiltration and invasion. Serous carcinoma is particularly notorious for local spread. Infiltration is quite efficiently seen in the serous carcinoma, and that is the reason why it possesses the irregular margin. And second is the intraductal spread. Carcinomatous cells in the breast often spread through the ducts and ductules. The examples are the Paget's disease, as we recently seen, the lobular carcinoma, tubular carcinoma, etc. Third is the lymphatic spread. Breast carcinoma spreads through this route, emboli and the permeation. Emboli: clusters of carcinoma cells sweat along with the lymphatic vessels, and through the permeation, it means that the columns of the cancer cell grow along the lumen of the lymphatic channels and gradually proceed to the regional lymph nodes. Dear students, here is the image of the Paget's disease, where the chronic eczematous eruption of the nipple is clearly seen, arises from the underlying carcinoma of the mammary duct. The same picture of the Paget's disease, the nipple is erupted. Now, axillary nodal spread, number of nodes involved, level of disease, extent of disease is individual nodes are there. Internal mammary nodal spread, supraclavicular nodes spread by the blood. The spread of the blood occurs later than the lymphatic spread. In the case of the carcinoma of the breast, cancer cells detach as emboli into the venules and are drifted through the venous blood to the lung first. Next is the intracoelomic spread. The cancer cell may spread into the peritoneal cavity from the breast cancer. This is mostly through the lymphatic spread, which involves the subdiaphragmatic and retroperitoneal lymph plexus from the plexus over the rectus sheath by the piercing rectus. Now, the clinical features are: breast cancer may occur at any age after puberty, though it easily occurs after 40 years. The symptoms are present with the painless lump in the breast, commonly in the upper and outer quadrant. The lump in the breast should always be suspected as a carcinoma unless proved otherwise. This should be the remember. Pain is conspicuous by its absence. Sometimes a bigger mass may give rise to a discomfort with the referred pain. No pain, only inflammatory carcinoma is painful. Discharge through nipple is not usual. Recent retraction of the nipple may be noticed by the intelligent patients. Sometimes the patient complains of the metastatic symptoms, remains unaware of the primary cancer in the breast. Now, the local examination by the inspection, the retraction of the nipple and dimpling of the skin may be obviously. The nipple of the affected side may be raised from the normal level or of its fellow. Retraction of the nipple can be best ascertained by the asking the patients to hold the arm up. PD orange may be the obvious in a few cases. PD orange is due to the cutaneous lymphatic edema. These are the symptoms. Local examinations. Then, on the palpation, the breast lump, which is the best palpated by the flat of the hands, is probably a case of carcinoma. Fibroadenoma and the fibrodenoma are much better palpated with the fingers and the thumbs. Axillary lymph nodes are always palpable due to their involvement. Attempt should always be made to find out if there is any distant metastasis. In advanced stage, direct invasion of the skin and dermal lymphatics by the cancer cells takes place. Now, the clinical staging of the neoplasms, malignant tumors of the breast, that is, the clinical staging is an attempt by the surgeon to identify the extent of the malignant lesion based on the clinical examination and special investigations. These clinical staging in use at present: the Manchester system, the Columbia system, and the TNM, that is the tumor node and metastasis system. By far, the TNM classification has achieved the widespread acceptance rather than the Manchester and Columbia system. Now, the TNM system, first presented by the International Union Against Cancer, organized in 1959 by the American College of Surgeons. It is based on the clinical observation related to the tumors. T for tumors, regional lymph nodes for N, and distant metastasis M. Tumor T0 is no demonstrable tumor. N0 no clinically palpable axillary lymph nodes. T1 tumor of 2 cm, T2 tumors of 2 to 5 cm, T3 greater than 5 cm, and T4 is the tumor of any size, any of the following: skin infiltration, ulceration, and skin edema, that is the PD orange pectoral muscles of the chest wall attachment. Now, the tumor node, that is the regional lymph node. N0 means no clinically palpable axillary lymph nodes. N1 clinically palpable lymph nodes. N2 palpable and fixed lymph nodes. N3 is the homolateral supra or infraclavicular nodes considered to metastasis. Now, for the metastasis, distant metastasis, M0 and M1 is clinically and radiological evidence of the metastasis. Now, the special investigations is to be made in the breast cancers are the mammography, zero radiography, selenium coated film, thermography, ultrasound, aspiration and biopsy FNAC. First, the mammography, X-ray examination of the breast. Special and careful techniques are necessary with fine grained X-ray film. Second is the zero radiotherapy. It is basically the same technically on the mammography, except that the image is recorded and selenium coated film producing a positive impression to make it easier. Third is the thermography. The skin over the malignant tumor of the breast is usually warmer than the surrounding area. Ultrasound. This is an important diagnostic tool in many organs system, but its application in breast cancer detection remains in the development stage. Now the aspiration. This is the performed in case of the cystic lump of the breast which were preliminarily thought to be benign. Now search for distal metastases, chest X-ray, bone scan, liver scan, computed tomography, that is CT scan, biochemical studies has to be performed. Increased alkaline phosphatase for bone and liver metastases, gamma glutamyl transaminase, serum carcinoma embryonic antigen, that is the CEA, should be the tumor marker and should be done. Treatment, that is the curing the local disease to minimize the untoward side effect and disabilities. Now the treatment of early breast cancers, that is the stage 1 and stage 2 are the lumpectomy, that is the thyrectomy, wide local excision, subcutaneous mastectomy with prosthetic replacement, total mastectomy and Halsted radical mastectomy. Halsted radical mastectomy, following the structures are removed, that is the whole breast, portion of the skin overlying the tumor which should always include the nipple, subcutaneous fat and deep fascia, whole of the pectoralis major, pectoralis minor and pectoral fascia, upper part of the appendices of the external oblique and few digitations of the serratus anterior, faulty and loose regular tissues, all these should be removed in the Halsted radical mastectomy. Now the structures to be saved in the mastectomy, those are the axillary vein and cephalic vein, long thoracic nerve of Bell supplying the serratus anterior, the nerve of latissimus dorsi may be sacrificed if required, modified radical mastectomy, axillary nodal clearance, extended radical mastectomy, internal mammary group, mediastinal and supraclavicular lymph nodes are also removed along with the axillary nodes dissection. Management of the axillary nodes, two main options is there, the complete axillary node and the on-axillary node sample, that is the sentinel node biopsy and lymphoscintigraphy. Now the adjuvant therapy, that is the adjuvant chemotherapy, cyclophosphamide, doxorubicin, adriamycin or methotrexate and 5-fluorouracil should be given. 12 cycle of the treatment by every 2 weekly. Adjuvant hormonal therapy is the hormonal receptor. Breast cancer cell have specimen proteins, available receptor protein, that is the estrogen receptor, ER protection receptor is a PR. ER and PR assay is the 19 m fresh tissue from the tumor has to be taken and rapidly frozen in -70° centigrade. Specimen homogenization and centrifugation, then incubation with the H3 tritium labeled estradiol 17 beta, that unbound the hormone is removed from the incubation mixture and bound estrogen sediment is measured. Value, if the value is more than 10 femtomoles per milligram, protein is receptor positive, and less than the 3 to 4 femtomoles per milligram, protein is receptor negative. Now the tamoxifen, a weak estrogen agonist but acts like a competitive antagonist of estrogen. Tamoxifen is the most widely used hormonal treatment in the breast cancer at the present day. Effect of the tamoxifen found in the first 5 years and continues for at least 10 years. Duration of the treatment, that is the 2 to 5 years. The effect of the tamoxifen is favorable irrespective of the estrogen receptor, that is the ER. Status of the tumors through ER, rich tumors achieve greater reduction in size with less risk of the relapse. Now the side effects of this tamoxifen are the nausea, weight gain, vaginal dryness or discharge. Tamoxifen should better be given to women whose tumors are positive for hormone receptor, that is the ER. Now the Zoladex, a luteinizing hormone releasing hormone antagonist, effect is the same as a chemical oophorectomy. Now the radiotherapy following mastectomy is only used in extensive local disease with inflammation of the chest wall. Third is the newer imaging for breast diseases are the magnetic resonance imaging, that is the MRI of the breast, nuclear medicine based breast imaging techniques. These are the new imaging technique for the breast diseases. Now the management of the advanced cases of the breast, that is the locally advanced cancer stage 3, ranging from a large fungated mass in the breast to a very small mass in the breast with large and fixed axillary lymph nodes. Locally advanced breast cancer is associated with the poor prognosis and a high local recurrence rate is there. Surgery for endocrine therapy and chemotherapy and radiotherapy should be given. Specific problems in the advanced disease is the bone metastasis, brain metastasis, pleural effusion and ascites. Palliative care, problem and treatment, regional or local recurrence is there, local radiotherapy. skeleton pain, analgesic and radiotherapy, dyspnea with effusion, intercostal drainage plus intrapleural cytotoxic drug, hepatic metastasis is there, then adequate the endocrine therapy with the corticosteroids, hypercalcemia, then the corticosteroids and calcitonin and phosphates should be given, paralysis from the cord comparison, then the emergency laminectomy should be performed. Now, the reconstruction of the breast after total mastectomy, there is the two methods of the reconstruction of the breast is the reconstruction with the subcutaneous and subpectoral implants by implanting the various breast implants there and pedicles and free myocutaneous flaps. These are the method of the reconstruction of the breast. Now, the next point is the sarcoma of the breast. There is the various sarcomas which may be found in the breast such as the liposarcoma, rhabdomyosarcoma, fibrosarcoma, hemangiosarcoma and lymphosarcoma. But these are the rare. Cystosarcoma is the most common sarcoma. Treatment is a wide local excision with the total mastectomy, and the spread of the sarcoma is like other sarcomas anywhere in the body spread mainly through the blood. Local inflammation is the next type of the spread, and lymph spread of the sarcoma is rare. Now the prognosis of all sarcomas of the breast are relatively good than other sarcomas in the body. Only the prognosis of the angiosarcoma is worse as it tends to early blood-borne metastasis to the lung. Dear students, here we explore these points. To know details about the benign and malignant neoplasm of the breast, you must refer the textbook of the surgery. And now here is the end of our surgery lecture number 101, that is the tumors of the breast. Thank you.